This is Neil Halsey again with part 2 of our session on causality. Let's talk now about case reports. As mentioned in part 1, we need reporting of adverse events in order to understand new adverse events that may arise or generate data from epidemiologic studies that might show an increased risk. But an individual case report, or even a collection of a series of case reports, doesn't provide us with the data we need in the 2x2 table to calculate any epidemiologic data. There are many misunderstandings about case reports and misuse of case reports, as was most evident with the false assumption that MMR caused autism, published initially in 1998 by Andrew Wakefield. A paper was later retracted, and some of the data were shown to be falsified, and so forth. We won't go through all that history here. You can read about it separately. But we continue to see bad science in case reports. This is just one such example, where there's an assumption that neurologic diseases in particular that occurred sometimes months after the vaccine was given caused the events. This was with HPV vaccine and reporting 4 cases where they occurred 4, 5, an unknown number of months after the vaccine. The false assumption of causal associations based on temporal relationships is our biggest problem that we have today in understandings of vaccine safety. In Latin, this is known as post hoc ergo propter hoc, or after this because of this. Just assume something was causally related that occurred after the event. We've all actually made this mistake, I'm certain, in our own lives with certain things that have gone wrong or bad in our lives or relatives' lives and assumed it was due to something that happened hours or days prior to that. But case reports are an integral part of our medical education. They're put in the most prominent journals. They're with illustrative examples. I learned a lot through my medical career, and I'm sure many of you have learned about clinical diseases due to case reports. There are now more than 25 journals that publish only case reports. So this is a widely accepted method of teaching. In fact, case reports are sort of integral to our DNA. They've been with us since the prehistoric times, and we've learned throughout our entire lives from stories. Storytelling is a very useful method for education at all levels. The limitations with regard to these passively acquired case reports for causality assessment include that you often have incomplete data on the clinical illness. Diagnosis isn't verified. It's usually only a temporal association that led to the reporting of the case report. When you try to assemble all of the cases that were reported, there's problems with both the numerators and the denominators, usually under-reporting, but sometimes selective reporting and reporting bias. So you cannot calculate true risks, but case reports can be used for hypothesis generation. There are some examples where causality has been established on individual case reports. Examples include identification of a live vaccine agent in normal sterile body fluid, such as individuals where the yellow fever vaccine virus was found in the liver. These patients had what's called yellow fever vaccine-associated viscotropic syndrome, where the vaccine virus just runs throughout the body, similar to wild-type yellow fever. I have isolated oral polio vaccine from the spinal fluid of children with aseptic meningitis. It can cause that. We've also seen a few examples where the live attenuated measles vaccine virus has been isolated from the lung of a child with leukemia, another one with HIV infection. You have to be careful with all of these to rule out that there wasn't a incidental or coincidental wild-type infection. We now can use genetic sequencing of these viruses to determine if they were from vaccine origin or wild-type origin. This was a common problem as we introduced varicella vaccine in my country many years ago now. Causality is not established with single reports of antigen detection or polymerase chain reaction, PCR, identification of the agent without genetic sequencing, because we've had many false positives in laboratories with contamination at every step in the process of specimen collection or in the laboratory. And again, you can have coincidental infection. If we do not have an isolation of a live vaccine agent, then generally we cannot determine a causal relationship. But there are possible exceptions to this general rule. With injection site reactions, if someone develops tenderness, pain, swelling, or other reactions at the injection site, these usually occur within a few minutes to perhaps a few hours or maybe a day or two after the injection, and in the absence of some other possible cause, such as trauma, then we usually conclude that the injection was the likely cause of the adverse event. We'll go into immediate hypersensitivity reactions in just a moment. We also have repeat challenge as a criteria that is used widely in drug testing, but we don't have a lot of evidence from vaccines about repeat challenge, and the science here is a bit unclear. We haven't standardized criteria for what constitute a true repeat challenge that constitutes evidence for a causal relationship. More work will be done in the near future on this. When a causal relationship has already been established from epidemiologic studies and alternative causes have been ruled out, then we often conclude a causal relationship has been established if it's within a time window of known increased risk. We will go into this in more detail in a moment. For immediate hypersensitivity reactions, the pathogenesis is known. We believe most of these are caused by IgE antibody, as we've gone through earlier. There's a short interval from the administration of the vaccine to the onset of the reaction, and it makes it unlikely for other exposures to be involved in causality, but not impossible. I now have 3 individuals who had received a vaccine and then went to a restaurant, ate food. In 2 of the instances, it was seafood, developed hives and some other signs of immediate hypersensitivity reaction. Initially, people thought it might have been due to the vaccine, but careful investigations, including skin testing, revealed it was the seafood. And skin testing is a tool that we Let's go through an example where there's a known causal relationship between a vaccine and an adverse event, such as a febrile seizure occurring 7 or 10 days after measles vaccine. It's within the time window of, but if a child developed fever 7 days or a febrile seizure 7 days after receipt of the measles vaccine, then it's within the time window of increased risk. Because we don't have a specific laboratory test to determine that it was due to the vaccine, we may have some uncertainty, but we assume it was causally related. But realize that other children who were already immune to measles had a small increased rate of fever. This is not due to the vaccine, but due to intercurrent illnesses, which occur commonly in the young children who were involved in this study. So we just can't be absolutely certain on an individual basis that this febrile seizure was caused by the vaccine virus. In the United States, the Clinical Immunization Safety Assessment program developed an algorithm approach to assessment of individual cases. Our objectives were to help educate providers on the steps that were necessary to assess causality on individual cases, to standardize the approach for assessing causality in individual patients, and to improve the understanding of the terms that we use to describe causal relationships. One of the problems that we identified is that the same terms were being used to describe the certainty of a diagnosis as were being used to assess causal relationships: definite, probable, possible, unlikely, and unknown. So we decided to not use those terms in the algorithm and to come up with different terminology that more accurately described the likelihood of the causal relationship. This is the first of 2 pages on the causality algorithm. There isn't time to go through in depth all of the nuances here. There's a manuscript that's referenced at the bottom right that I encourage you to read. But what we do is we take an individual case and we go through in a logical order specific questions that must be answered. Is the diagnosis correct? Is there evidence for other causes? Is there a known causal relationship with the vaccine? And then you follow the answers, yes, no, or uncertain, to various branches that take you to conclusions. It's best to see this in the form of our example of this febrile seizure that occurred in a 12-month-old 7 days after receipt of MMR. Is the diagnosis correct? Yes. Febrile seizure was observed, clearly described. Is there evidence for other causes? In this example, there was not. Is there a known causal relationship with the vaccine? Yes. Was the event within the time window of increased risk? And the answer was yes. So what we say here, it was consistent with a causal relationship, is the best descriptive language that we came up with. If we change, and this is a different case, both of these are real cases, a febrile seizure 4 days after MMR, then the answer to that question, was the event within the time window of increased risk? The answer is no. There's no qualifying factor to explain why the vaccine might have caused the febrile seizure in a shorter time period, and so we can say that it's inconsistent with the causal relationship. Now, the whole process is a bit more complicated. There are many more branches, and the second page, not time to go through all of that. But the advantage of this algorithm approach is that it's visual, it's standardized, it's transparent, you can track the assessments, you can revise the assessments as new data become available. And in the investigation of individual cases of adverse events, it's not uncommon for new information to become available, especially about other possible causes or underlying diseases. WHO, a few years ago, revised their approach to individual cases, starting from the CISA causality algorithm. They developed a new tool that is useful in assessing causality on an individual basis. They modified our approach by adapting it to countries where there are less resources available to be able to do in-depth clinical and other investigation of individual cases. And there's an article that I participated in the publication of, led by Alberto Tosi and others at WHO and from other countries, that you can use to go through this. There's also an online tool that WHO maintains to assist people in investigating adverse events. Here, there's a 4-step process. First, a determination of eligibility to be able to go through a causality assessment, a checklist of the information that is needed to be collected, and then you go through an algorithm approach and then a final classification. The eligibility is to make sure that information has been gathered, there's been an investigation, you identify the vaccines that the individual received, and you select the evidence that's going to be presented. I won't go through all of that. A checklist, asking some of the same questions about evidence for other causes and known causal association, the timing of it, and so forth. And you put it through the algorithm with many of the same questions that are in the CISA algorithm. And then finally, a classification of the adverse event. And the classification schemes are here. We don't have time in this presentation, but I encourage you to take a few cases that you may be aware of and put them through this classification. This tool is now in use and being used for training people on assessment of causality throughout the developing world by individuals working through WHO and other organizations. I believe one of the things that we need to do from a scientific standpoint in the medical community is to change the way that medical journals publish individual case reports. We have standardized guidelines for reporting the results of clinical trials. I'm not going to go through this here, but medical journals now have agreed that if you're going to do a clinical trial, you have to show all of the methods you used, where everybody who was enrolled in the trial came out in the trial. You can't just selectively report subgroups and come up with a conclusion that you would like. I believe that we need standard guidelines for reporting of case reports, including people being required to go through a causal assessment process through either the CISA method or through the WHO method to show how they came to the conclusions that they came to about something being possibly causally related to vaccines. Well, in conclusion, I'll tell you that I've learned in every country that I've worked in or traveled to and collaborated with people that there's poor understanding of causality assessment, and that contributes to our problems in vaccine safety today. We need standardized reporting of reports, of assumptions of causal relationships, but most importantly, throughout the entire process is that we all need to work to demand good science from everybody involved in the process. Well, I hope you've learned something through these presentations, and I thank you very much for the opportunity to participate, and good luck to everyone.